احنا النهارده هنا في بورتوروز بسلوفينيا بدعوة كريمة من شركة ميسي، أحد البايونيرز في مجال التحول الرقمي الطبي. جايين نعرض تجربتنا في DNC التجربة المصرية في مجال الاستخدامات الرقمية للأجهزة الطبية في مرضى السكر المصريين.
Hello, good evening. And I know I'm probably standing between you and dinner, so I'll be pretty quick. So, excuse me, I lost it. Okay, so I'm a diabetologist. I'm based in Cairo, Egypt, which is another totally different part of the world. And I run a tertiary center for management of diabetes and its complications. Now, first of all, diabetes has been recognized as one of the main factors causing atherosclerosis. This association has been made since 1948 by Professor Howard Root at the University of Harvard. Throughout the years, our management has evolved to include more and more aspects of risk factors concerning atherosclerosis. And all diabetes guidelines, all of them, recommend the screening for atherosclerotic cardiovascular disease and treating the risk factors accordingly. Now, concerning peripheral arterial disease, it's atherosclerosis of the extremities, usually always lower, even though throughout the years I have seen a couple of upper limb peripheral arterial disease. They're doing several thousand, so it's probably nothing. Anyway, mild peripheral arterial disease may be totally asymptomatic, and by the way, mild peripheral arterial disease is just beautiful when diagnosed, because these patients can easily and extremely cheaply be treated and have their problems solved, and that's it. And the biggest challenge with mild peripheral arterial disease is that these patients are totally asymptomatic. They have no problem whatsoever. When we manage to actually screen them, we manage to diagnose them, it's usually the machine's problem. The patient says, there's nothing wrong with me. Okay? It is so because they have absolutely no symptoms. And the good thing is that it is absolutely reversible. And I'm talking about within a few months. And I have seen this many times. Now, severe peripheral arterial disease, we see skin atrophy, we see ulcers, we see gangrene. It's something really horrible. I'm really unhappy when I see these people. We try medical treatment first. It usually fails, and then we go to surgical treatment, which isn't something nice at all. Additionally, it is extremely expensive, with results which usually aren't that satisfactory, usually speaking. So diagnosis by history, clinical presentation, and clinical examination, and by ABI. There are much more complicated diagnostic modalities like duplex, CT angiography, etc. The list is becoming more and more long. So, prevalence of peripheral arterial disease varies quite a lot according to population studied, and it increases with age. We're talking about more than 25% of above 80-year-olds, and 11.2% of American diabetics who are aged above 40 have peripheral arterial disease. If we go to the guidelines, this I have taken out of the clinical examination guidelines from the standards of care of the American Diabetes Association. It says that all patients should have their pedal pulses palpated, and if diminished, you should proceed to ABI. And this is recommendation 10.4 from the ADA guidelines. It says in asymptomatic individuals with diabetes and age above 50, microvascular disease in any location, foot complications, or any end organ damage from diabetes, screening with peripheral arterial disease with ankle brachial index testing is recommended to guide treatment for cardiovascular disease prevention and limb preservation. In individuals with diabetes of duration more than 10 years, screening for peripheral arterial disease should be considered. Okay. Manual ankle brachial index assessment, as was told by my previous colleague, it's quite good. It gives good results, but it takes half an hour. So you're using a room and medical personnel and equipment for 30 minutes to get a result. Automated ABI has been very well validated, and it takes around 3 or 4 minutes to do. So it makes life much, much, much easier. The interpretation less than 0.5 means severe peripheral arterial disease. Between 0.51 and 0.9 means we have considerable abnormal PAD, and 0.91 to 0.99 is borderline. These people should be referred for further tests if not present in the same facility. And between 1 and 1.4 is normal. Above 1.41 means incompressible vessels. Incompressible vessels mean that we have heavy atherosclerosis. These are calcified vessels. Now, the prevalence of peripheral arterial disease in Egyptians has never been assessed. All patients coming to our clinic have their ABI measured as part of their assessment. Speaking of, I remember from 2 talks ago, there was talk about having done, I think, 600 ABI tests in the past 3 years. Our average is 250 patients per month, 250 tests per month. Okay, so like the number was very shocking for me. Okay, and screening everyone, if we do 250 tests per month, and let's say we have 10% of them with peripheral arterial disease, we managed to pick up 25 patients with peripheral arterial disease per month. Okay, and these are 25 patients who have avoided future amputations, for future ischemic heart disease events. Now, this is worth something. Okay, it should be done to everyone, at least in my opinion. Okay. So, the assessment of ABI was done with an automated Mesi ABI device. Okay, and thank you a lot. I really appreciate it with the cloud. Okay, yes, it is true. All my data has been sent to the cloud, and having been sent to the cloud, I can download it for further assessment. This I mean statistically. Okay, this comes from your website. Okay, I really wish I looked as handsome as this wonderful doctor here, but I'm not. And I really wish also my nurse looked as beautiful as this fine lady, but she's not. It would have made our lives much better. Anyway, so we assessed a cohort of 900 patients who are downloaded from your cloud and had all of their data in my system. We're talking about real-world data, which is usually very messy. Anyway, we took the very first 900 who had full data, and 410 were males, that's 45%. The mean age was 51, the mean BMI was 33.2, mean hemoglobin A1C was 8.8, and mean LDL was 106. 605 of them were smokers, that's 67% or 2/3. Okay. 99 patients had peripheral arterial disease, that's 11%. And the only positive correlations were with blood pressure and pulse. But our facility is a tertiary center. And many of our patients have already been started on statins before arriving to our clinic. So we adjusted our results, our tests to those on medication. And we found that patients with peripheral arterial disease had a higher LDL. P-value was 0.013. So the prevalence of peripheral arterial disease in Egyptian diabetics is 11%, which is pretty similar to the Americans, which is 11.2%. It correlates with the same vascular risk factors as ischemic heart disease. Patients with diabetes should be assessed for peripheral arterial disease in addition to vascular risk factors. This group has the same lipid goals as patients with ischemic heart disease. And thank you.
بعد ما خلصنا المحاضرة الحضور كان عندهم أسئلة كتير على المحاضرة بتاعتنا والمحاضرة اللي قبلها، فتم دعوتنا أنا والمحاضرين زمايلي لمناقشة اللي قلناه والإجابة على أسئلتهم.
Okay, we already have one question. Great. So if the participants and our panelists are ready, we will start with this one. So we are often asked by cardiologists and diabetologists, having diagnosed PAD on a patient, what is the next step? What am I supposed to do with this information? Just first, let's grab a mic so that everybody can hear us.
Okay, so you're supposed to do a lot actually.
Okay, so let's go step by step.
Step by step. Number one is assessment. By the word assessment, okay, he has peripheral arterial disease. Does he also have ischemic heart disease? Because they often go hand in hand. Next step is, how is his diabetes going? I should put the patient on a much stricter diabetes control. I have very stringent blood pressure goals. I should use a vasodilator. And then we go into the fight between diabetologists and cardiologists. Cardiologists will go straight to very potent beta blockers. We fight with them because for us the strong potent beta blockers will increase the peripheral arterial disease effect, etc., etc. But we both agree that to give a maximum possible statin, plus minus ezetimibe, plus minus bempedoic acid, plus minus a PCSK9, plus a vasodilator and 2 antiplatelets at least. And that's it.
Very short and brief answer.
And by the way, it does work.
It does?
It does work. I have a ton of data saying it works.
So speaking from experience.
Yes.
Great. Petra, Nina, would you like to add something?
Yeah, I wouldn't because I don't I don't do the measurements, but I've spoken to Nina about this multidisciplinary approach, and I think you do have some next steps, right?
Our next step is that patients with PAD, when we measure it and it's significantly high, we send them to vascular hospital to next assessment to do.
That's very good management too. Referring to a special center is extremely good management, and I strongly advise it.
Thank you very much. So let's move to the next question. So after diagnosing a patient with a mild PAD, what treatment approach do you usually follow? Do you prescribe oh my God, no. Thank you very much. As a part of your...
By Bayer.
Yeah, okay, so do you prescribe it as part of your management plan?
Definitely, but it won't do anything without maximum statin, maximum blood pressure control, maximum diabetes control, aspirin or claviclopidogrel or whatever. Zolpidem is also a very good option. Pentoxifenone is a good option, and then add on rivaroxaban 2.5 milligrams twice daily, but never alone. It will do nothing.
Mm-hmm. Nina, something to add? No? Okay. Thank you for the answer. Do you think it is possible you missed some PAD in the diabetic group due to mediocalcosis? It's above the green question. It's hard to read, but...
Yes, these are the patients who have an ABI of more than 1.4, okay? And for these people, I already have heavily atherosclerosed vessels. Next step is, they do have some form of arterial diseases now. The next question is the flow going to the extremities? Has it been compromised or not? There are several modalities in order to see this, including CT angiography or even simple peak systolic velocity measurement using duplex at the posterior tibial artery and the dorsalis pedis, or using your TBI.
That's what I wanted to add. Thank you. Precisely that. So we could see a study from Hungary where it was determined that a combination of having an ABI and TBI in an assessment of a high-risk population can really discover almost all the patients, so above 90% of patients. So yeah, absolutely, I agree with that. Even especially if you don't have an immediate access to further vascular imaging, which can be very expensive and can have a quite long waiting lines. Correct?
I totally agree.
Thank you.
Next question is dedicated to Nina. You're working in a university level hospital, so where do you perform ABA examinations on hospital departments, for which patients?
Okay, so yes, as I said, I'm working in University Hospital in Golnik and in Department for Cardiology. So the ABA examinations we measure at our department, so in Cardiology department, and for almost every patient with risk of ABA, of PAD symptoms. So, yes.
Maybe
May I ask a question?
Yeah,
to
of
you?
course.
Why not everyone? What will he lose? The test costs nothing if you already have the device. Why not everyone? And you probably will have enough. This is like 3 minutes. How many patients can you see? Okay. Why not everyone? Because as I was saying, we're doing 250 tests per month, 250 average, 250 patients per month coming to see me. Okay, and when we do everyone, this is 25 limbs, at least 25 limbs saved, if not more. Why not?
I'm sure I will change this. Okay.
Thank you.
Nina, maybe one follow-up question. Namely, what advice would you give to other healthcare professionals in cardiology when it comes to performing ABI measurements? Advice,
Advice,
for
yes.
other.
Like doctor said that that we need to measure everyone in every patient that comes to Department of Cardiology.
So
If he already goes to cardiology, he's already high risk in the first place. Okay? Just going through your door means he's high risk.
the main takeaway from this panel. Thank you for the answer, and let's see the next question. Okay, what about patients' effort after getting to know that has asymptomatic PAD? Quitting smoking, walking more? Dr. Hani?
Definitely.
Yes, to both.
Quit smoking, exercise, walk, because this increases the new vascularization, increases the new vessels being formed, and very strong diabetes treatment, very strong high blood pressure treatment, extremely strong statin treatment. By the way, there is a ton of rubbish on the internet about the evils of lipid lowering and how it is bad. And okay, like, this is something the whole medical community should stand against, but it's very important. Usually, we don't need to anticoagulate them. We don't need to get them like one antiplatelet should be more than enough, it's still fine. And these people actually cure. And this is beautiful. How many things do we have in our profession that we can actually cure? Not much. Mild PD, when I see mild PD, I'm very happy because it is something I can solve once and for all, and the problem will go away. And that's it.
But do patients actually listen to your advice?
The word PAD equals, in the patient's mind, it equals gangrene, amputation. The quality of life post an amputation of 2 toes is worse than having a major stroke with hemiplegia. Okay?
So they take it very
They take it very seriously, and it's ultra scary for them. And the moment they know there is light at the end of the tunnel and there is a way out of it, and they can actually run away from this problem, and they can make it go away, and they can continue to live naturally, they grasp it with everything they've got.
Thanks. Petra,
I just
you
have a
would like
follow-up
to-
question for Nina because it's a little bit of a different department. Do you do any type of consulting for patients with PAD? You know what to do before being referred, reversing lifestyle choices, stopping smoking, and so on. Do you also do that?
Yeah, we have a short questionnaire before we do measurements of PAD. So when we talk to the patients, we usually know a lot of things about. So is he a smoker? If he had pain in legs while walking and stuff like that. So usually when it comes to topic about smoking, we also have some healthcare school about quitting smoking. So we send them also to this group of nurses who are trying to teach them stop smoking. So about smoking, yeah. It's like that.
So the similar advice. Let's move on to the next question. What are the limitations of ABI measurement on diabetic patients with Mockenberg calcification, and does TBI measurement totally resolve them?
That's a very difficult question. Okay.
We have time.
Okay, now, Mockenberg calcification, we can look at it as the loss of elasticity in different segments of peripheral arterial vessels, but does not obstruct flow. Okay, so it's the type which can give you like 1 point, the higher part. And does TBI solve it? I believe pretty much, yes, pretty much. But other forms of more complicated assessments, such as CT angiography, may be needed, but let's be real. Like if I have someone who has an ABI of more than 1.4, like 1.5, 1.6, and they do a TBI and it's fine, and I wouldn't put this person through the hassle of taking contrast to do a scan. I personally wouldn't do that.
What do you think about pulse wave velocity?
Pulse wave velocity is one of the most underrated, extremely powerful methods in order to assess atherosclerosis of the body as a whole. There was a very big hype about it with the introduction of AC inhibitors. I think that was like 25, 30 years ago. And it was the main, it was the main thing with when the HOPE study came out and the Hooper study came out around 2000, 2005, this era. Okay, and for some reason we have totally forgotten it. Even though, let's be like, if you speak to someone a bit older than I am, he will write sonnets about the beauty of pulse wave velocity. Okay, if you speak to someone a bit younger than I am, he'll probably ask you, "What's that? I've never heard of it." Okay, but I personally believe it's something very powerful. Especially combined with other risk factors such as Abi, lipoprotein little a, the score system for ischemic heart disease, high sensitive CRP, can actually do a lot of miracles with that. The only thing is, what actually, in my opinion, what Mesi needs to do is to go around telling people, guys, there's something called pulse wave velocity. Have you ever heard about it? I believe it will make a huge difference. I have been looking into it. I think there's another Hungarian company doing this pulse wave velocity assessment device. It's pretty complicated as far as I understand. But if I actually have something that tells me the atherosclerotic status of the person as a whole, I have something to work with. I have a baseline. I have something to follow up. Speaking of, I think after your question, I definitely will add to my devices, I will add a pulse wave velocity module, and I'll talk to the CEO here. Maybe he can talk to someone to give me a discount or something.
I'll talk to him. I just wanted to mention regarding pulse wave velocity, it has been really emphasized in the latest guidelines of the Artery Society. So it has been brought into the guidelines more specifically. Please, sorry if I'm not correct here, but if it's not this year, it's end of last year, so fairly recently. And they emphasize also the importance of brachial ankle pulse wave velocity, which is what is measured with the M-tablet device. We are doing some more projects regarding this, but yes, I would agree with you that we will talk to the CEO and we'll see what we can do, okay?
Please.
In UAE, we start with some vascular surgeons when the patient is with ABI more than 1, and the oscillation graphs showing uncontracted arteries, we go for pulse wave velocity and TBI. So we can see the whole measurements, if it's normal, it's not normal, so we can take the second step. It will be more detailed.
Thank you. Okay, let's move on. We only have 4 more minutes left and 4 more questions. Great. So what is your opinion on exercise ABI testing? Do you find it useful in diagnosing borderline or early stage PAD?
Now, that was a very big fight I had with your medical department at Mesi. Because
Why?
Yes.
I think we need a little bit
yes,
background.
okay, I had a patient with a false negative test. Okay, and I reported it as I should. The guys, I have a problem here. Please take a look into it. And then the medical department answered me, when you see there's something, did you do this? Did you do that? Did you do this? Blah 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 blah. Yes, I did all of it. Okay, and then they went back into something, and then at the end I told them, okay, now listen, if you have if you have doubt, you should have told me. I should do an exercise ABI. Basically, an exercise ABI, for whoever doesn't know it, you do a normal ABI and it's normal, and you still can't feel the pulses. So you get this guy to, the idea, whoever your patient is, to run on a treadmill for quite some time, or go up the stairs, or do anything, and then repeat the test after this. What happens is, with exercise, the lactic acid and the metabolites make all the vessels dilate. Okay, so in this case, normal vessels will dilate, diseased vessels will not dilate. So this will make the ankle brachial gap become much larger. Okay, and this will pick up what the problem is.
And with M-Tablet, sorry, I'm like, this is a commercial, but I mean it. With M-Tablet, you can create protocols, so custom protocols where you can do the stress ABI test as well, where you first do an ordinary measurement, so ABI, then you make your patient walk, and then in the same protocol, you can do the follow-up ABI measurement, and it makes your care much easier in that way.
See this guy sitting down there? This is
Yes.
Dr. Bassel, he's a cardiologist.
I know him
He's a
very
local
well.
affiliate in Egypt, and he never told me anything about this.
We have some homework to do. I pass them.
Well, a topic to discuss during
Tell them how
lunch
many
break.
devices you have in your clinic, please.
So should we move to the next question? How reversible is PAD? Dr. Hani.
Extremely reversible, if caught early. The later it is, when we have heavy calcification, there's basically nothing to do. If caught early, when we still have soft atherosclerotic patches, it is totally 100% reversible, absolutely.
Petra, you wanted to add something?
No, I just, this is Dr. Hani's show, so you can tell us some more, please. I'm looking forward to continue the conversation with both of you.
Well, let's answer the last question. When will you decide to send the patient to interventionist?
Can we start with Nina here? When will
Nina?
you decide to send the patient on?
So when the test is abnormal, then the doctor sends it to the hospital for vascular disease. So like that.
How about the holistic assessment? So do you also focus on other factors, or is it just ABI, if ABI is abnormal, or if it's also the rest of the examination is abnormal?
This is the cardiology department.
Yeah, also with the rest of assessments. Yeah.
Dr. Hani, would you like to add something?
Okay, generally speaking, you do an intervention when you have one of two things. You have a wound, okay, with peripheral arterial disease with systolic velocity less than 35. This is one indication. The other thing is if you have resting pain and the patient fails treatment for 6 months, medical treatment for 6 months, unless of course it's a wound.
Do we have time for one last question? Yes, we do. Great. So, in your opinion, How close are brachial-based PWV measurements to the actual CF PWV values? Do you find them, oh gosh, reliable enough for clinical use?
Very important
Dr. Hani,
question.
I think.
So basically, the brachial-based pulse wave velocity is basically, okay, let's look at it this way. A heart vessel will conduct, because it doesn't expand with the pressure coming in from the systole, as a normal vessel will expand, so it will absorb some of this blood. If I have a calcified vessel, an atherosclerosed vessel, the pulse will propagate faster. Okay, so one wave of pulse will have higher velocity. That's what the pulse wave velocity means. The original way to measure it was carotid femoral. Okay, so that's the CF, so carotid femoral. So we find because the carotid is closer to the heart than the femoral artery. In this case, you'll get the pulse which will go to the carotid will be faster than the pulse which will go to the femoral artery as it passes through the massive aorta. Okay. Now, has the brachial pulse wave velocity has it been validated? Definitely yes. Okay. Have I personally used it? No. Do I have any opinion on it? I don't know. I have never used it, and Dr. Bassem here hasn't tried to convince me to do it. Okay. So I think these two beautiful ladies will probably have much more stuff to say about this than I do.
Thank you for your honesty. Yeah, this is about to change. You will use it. I wanted to mention that again, the Artery Society guidelines have recognized something that has previously been more recognized in the Asian population. So brachial ankle pulse wave velocity has been more prevalent over there, but now it's been brought into the guidelines, stating that there is the need for brachial ankle pulse wave velocity because it's much easier to be implemented in clinical routine. If you have carotid femoral pulse wave velocity, it's a great diagnostic tool. It's not going to be done on the at-risk population because of time constraints, because of training constraints. If you have an easy-to-use brachial ankle pulse wave velocity tool, it will be used. So that's the main thing. And also, yes, it has been validated.
Petra, we will give the last word to you because from what we heard, promoting early diagnostics bring enormous value to overall public health. So what would you say in one short sentence, what is the role of medical device companies in such projects?
I can speak for our company because I haven't worked for any other manufacturers, but it goes beyond offering a simple device. Yeah, we make a tool that is easy to use, but what we do with this tool is make it implementable into clinical workflows. This means that it can be brought into the primary care, it can be brought into every practice where the patients, I don't know, who are 65 and smoke are being seen. And previously this hasn't been done. So this is one aspect. Another aspect is, of course, the cooperation with clinical people, so with healthcare professionals, with initiatives, with studies, so with clinical research that further brings impact to these automated devices. And now this last thing that we have just started to explore, by integrating automated ABI, TBI, pulse wave velocity, so arterial assessment into a broader platform like mTablet, you can go beyond just PAD, you can go into comprehensive cardiovascular assessment, and this is what I'm excited about.
Petra, thank you very much. Mrs. Stuchec and Dr. Hani, thank you as well.